Okay, good morning, everybody. Please, if you have joined, indicate by writing your name. Let me know the person that has joined. Thank you. We need at least, as I always say, 60% of the class to join for us to begin. Okay, Umar Usman. Okay, thank you for joining. Maimuna Kasim. Thank you for being here. All right. Okay, please let's join on time so that we can begin. Okay, Saudatu, you're welcome. Sharifat, Bashir is here. Umar Gombe is here. Shoaib Idris is here. Let's join. We need at least 35 to begin the discussion. Okay, we only have 11 people here. Okay, Margaret and Lady is here. Lucy Chiroma is here. We need more people to join for us to start. Okay, we only have 12 people. Please encourage your colleagues to join. Right? Those who don't know how to do it, you guide them on how to do it. Lois is here. Okay, okay, we have 15 people. So, as I said, we need a reasonable number to start. Because if I start my discussion, I will not go back. Because, like yesterday, a lot of people joined late and they were asking me to repeat myself on some of the things I have discussed. I will not. Remember, the importance of this lecture or discussion is to guide you on the areas you read on the lecture note. Halima Dair is here, Fatima is here. All right. Because the lecture note is very big. If you are to read everything, you'll be overwhelmed. But if you attend this lecture, it's more of guiding you on the areas of concentration so that you don't have to read everything. But you need everything for knowledge sake. But I will not ask you everything in terms of exam, but for knowledge to build your skill as a community health worker. You need everything. But for the sake of exam, it's not everything that I'm going to ask you. So I've given enough time. So I think we'll begin. Anybody that comes late, as I said, I usually take attendance at the beginning, at the middle, and the end. So I think it's better we start. Okay, so yesterday we discussed about waist circumference, and I said that waist circumference in men when it's up to 102 and above is high. In women, when it's up to 88 and above is high. So, using waist circumference, there are two types of obesity using waist circumference. There is what is called Android obesity, like your Android phone. So there's what is called Android obesity. In Android obesity, the obesity or the person is large from his waist up. Android obesity is when someone is big or has obesity from his waist up, while the other part of the body is slim. That is Android obesity. The spelling of Android, just like your Android phone. Then you have gynecoid obesity from gyne or gynecology. So gyne is the one because android obesity is what you see in men. Men look bigger up. That's why it's called android. Android means manly. Gynecoid means like a woman. So gynecoid obesity is the one that is from the waist down. So generally women are bigger from the waist down. So using waist circumference and hip circumference, you classify obesity that way. You have android and gynecoid. What is the significance of this classification? So people that have android, that means they are bigger from the waist up. They are at risk of diabetes, hypertension, cholesterol problems, right? And the risk of people that have risk of android obesity are those who take alcohol, those who don't adhere to dietary advice. So the android obesity is even more significant in clinical practice than BMI because sometimes the BMI of someone will be falsely high because it's muscular. People that are muscular, uh, like somebody like me that is muscular. So if you check only BMI, somebody's BMI may be high, but he doesn't have a lot of fat. So, but if you check the android obesity, where is how big someone is from the waist up, right? Where you measure the waist circumference. If somebody has android obesity, he is more at risk of hypertension, diabetes, cholesterol problems, and the rest. So that means android obesity is very important. The next is gynecoid obesity, where you have more fat around the hips downward, which generally you see in women. So people that have gynecoid obesity don't have as much health risks as android obesity, right? And this one you see commonly in women, and is due to the action of estrogen, the female sex hormone. That's why women have it more than men, since men tend to have more of the male sex hormone, testosterone, while the women have more of their hormone estrogen. So it has less health risks compared to the android obesity. If you are following me, right? Yes, sir, yes, sir, yes, sir, so that I can proceed. Okay. If you're getting me right, yes, sir, or you can write proceed. Sir, let's keep going. All right, Hasana's getting me. That's good. And you're on good, 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 good. All right, so you're all getting me. So after explaining this obesity, I started discussing the complications of obesity. So today I'm going to make it a bit clearer, right? So one of the complications of obesity is one, it can affect the lungs. So people that are obese tend to snore a lot at night and sometimes they aspirate. So they have chest infection, they have problem with breathing. people that have obesity have fat in their liver, so they can develop liver cirrhosis from steatohepatitis, because that fat in liver can lead to other problems, right? So, as I said, attendance is extremely important. I'm taking note of people that are joining, because we are seeing only 20 people. If I decide to add 10 marks to people that join, no one should blame me. I'm taking note of the people that are part of all of them, all the names. I'm taking note of it. Okay, so it can affect the liver. It can also affect the reproductive system. Like in women, it can cause infertility. It can cause polycystic ovarian syndrome. Women that will have polycystic ovarian syndrome, they have problem with fertility. In men, it can cause erectile dysfunction because they will not have enough testosterone. Right? As I said earlier, it can cause osteoarthritis, problems with the joint. People that have obesity are more at risk of cancers than those who do not have obesity. Right? Also, people that have obesity are at risk of stroke. They are also at risk of heart attack. So you can see that obesity comes with a lot of problems. You know, gouty arthritis, right? People that have obesity are also at risk of gouty arthritis. That means high uric acid, which will accumulate in the joints. So you see that obesity has barrage of complications. And if something is not done, you see that patient will become morbidly obese with a lot of complications, and they tend not to live as long as those who do not have obesity. Okay, so how do you assess obesity? So for clinical practice, usually it's either the BMI, the waist circumference, or the waist hip ratio. Generally, that's what you use. We have talked about the BMI, we have talked about the waist circumference. The waist hip ratio is the ratio of the waist and the hip. The hip is the highest circumference uh, using the maximum protrusion of the buttocks. Then you measure the hip circumference. So the waist circumference over the hip circumference is the waist hip ratio. It's also very good or important like waist circumference. So the importance here is that if you have waist hip ratio in men that is um, above 0.96, there's increased risk of all these hypertension, diabetes, cholesterol problem. In women, if it is above 0.85, there's high risk of all those complications. So the ratio waist versus hip in men, if it's more than 0.96, right, then it is that individual is at risk of hypertension, diabetes, cholesterol problem, and other problems. While women, if it's more than 0.85, right? So that's another measurement that you do. So I expect that any adult that comes to your PHC, at least calculate his BMI, check his waist circumference and waist hip ratio, so that you will not just come treat patients just based on malaria, maybe typhoid, maybe anemia. No, look at their risks for non-communicable diseases, chronic diseases like hypertension, diabetes, right? So that you, as a community health worker who is at the pillar of preventive medicine, you see those at risk and you take measures to prevent those things coming up. So, but the other measurements of obesity are in the slide, like skin fold thickness, right? And other ones. I will not ask you that, but you can read it for better understanding. So the things I'll ask you is the ones I have discussed. So how do you manage obesity? The baseline for managing obesity is lifestyle changes. The truth is that if someone is obese and is not ready to stop sugars, refined sugars, simple sugars, is not ready. Because what I usually tell my patients is that the first step to prevent obesity is stop all refined sugars, all your soft drinks, all the things that you use for tea that have sugar, all your pastries like cake, donuts, whatever. If you're ready to lose weight, that's the first step. So, healthy lifestyle like diet, oh, and also that individual must stop saturated fat. We discussed that in diabetes, right? Apart from that, you must eat small with a lot of vegetables. Hope you guys are following my videos on YouTube. I have done some very important videos. I have done videos on dates, the Bino, right? Now that Ramadan will start on the first quarter, Ramadan will be in the first quarter of next year, I hope. So you as a preventive medicine specialist, you should know. So I did video on dates. I did videos on miyan kuka. I did videos on potato. I've done a lot of videos. If you're following, you will be equipped with the knowledge to be able to counsel patients on diet, right? That's why the benefit of joining that channel is not only for this lecture, it's for you to see other things. Okay, all right. So apart from diet, you do exercise. I said there is moderate, we need moderate exercise, 30 minutes of moderate exercise per day, 5 times a week. But for those who are young, agile, and strong, they can do vigorous exercise, 15 minutes a day, 3 times a week. That's about 75 minutes per week. But generally, in my practice, I recommend moderate exercise so that there will be minimal risk for injury. All right. So if you do lifestyle and diet and you are not getting result, you add medications. Some of the medication I have listed is like EcoSlim, a drug that does that. Um, some of the fat in the diet are not absorbed. There are other satiety. They make individual to get full easily. One of the medications is liraglutide. I use it a lot in my clinic. So there are medications that suppress appetite. There are medications that make you feel full easily. There are medications that reduce the absorption of fat from your diet. So that you. So if you try that medications and it doesn't work, then you have to do surgery. So surgery, what they do is reduce the size of the stomach so that if you eat a little, you feel full. You know, gastrectomy. Gastro is the stomach. So you cut some part of the stomach so that if someone eats, he feels full easily. Okay, so that is the management of obesity. So who is qualified for that surgery? Anybody that has class 3 obesity or morbid obesity, the best treatment for them is surgery. People that have class 2 obesity but they have other problems like diabetes, hypertension, uh, problem with the respiration, they also need surgery. For you that so some of you that go through social media a lot, you see that some of these celebrities have done surgery. One of them is Real Worry Pikin. She did the surgery that reduced the size of her stomach and she has lost a lot of weight. Previously, she was morbidly obese. So it is a surgery that helps someone to gain to go back to shape, reduce the risk of hypertension, diabetes, and other complications attributed to obesity. Okay, all right. So that will be all for obesity. If you have any question, ask. If you don't have any question, right? I understand. I understand. Let's go. Okay, let's write. If you understand, you write, I understand, so that I can proceed. Okay, so we see understood, I understand, I understand. Okay. No one has question on obesity. So, how many of you checked your BMI? I say you people should go and check your BMI and see. Did anybody check his own? It's very good, so that you know when you don't worry about drugs for obesity, right? It is not your place as a public health specialist, right? Is um to prevent obesity and to teach people lifestyle. So, but if it has reached the state of, if it has reached the state of treatment, please refer the patient to a specialist, weight loss specialist. Your own is to teach the individual lifestyle. Somebody is asking the main causes of obesity. We did that lecture yesterday. Please go and look at our video yesterday. We did that video yesterday on the causes. I feel like I didn't understand the interpretation of body fats. So the interpretation of body fats, I did not discuss that because it's not important vis-a-vis your exam. All right. That's why, because the methods of analyzing body fats is not readily available in this environment. So I don't want to bore you with that. But since you asked, the body fat is, everybody has the percentage of his body that is fat. Men have, if the percentage is more than 20, so men it should be 20 or below, while a woman should be 25 or below. And the only way to assess body fat in an individual, you have to do MRI and other tests which you will see in your note, like bioelectric impedance, where you step on a machine and that machine will calculate your body fat, right? So either MRI or bioelectric impedance or other things. So all these tests, they are not readily available and they are not used in clinical practice. They are only used most of the time in research. The only one you use in clinical practice is your BMI, your waist circumference, your hip waist circumference hip ratio, right? So these ones are not typically used in clinical practice, only in research. Okay. Nanladi Magaji, were you not here when we discussed the types? I said there is android obesity and gynecoid obesity. Android, like men, men are bigger from waist up. Then gynecoid obesity is from waist down, just like gyne from women. I said that people that have android obesity, people that are bigger, the obesity, the increased fat is more from waist up, are more at risk of hypertension, diabetes, and other complications. So these are the types. Android, that's from the word men, because men have a bigger upwards. Gynecoids, from the word gyne, women. Women are bigger from waist down. So people that have excess fat from waist up are the ones that have android obesity. And uh, if you have android obesity, you are more at risk of hypertension, diabetes, and other complications. Yes, when I resume, there will be revision before exam. So we'll do both the waist and hip circumference measurement. But as I said earlier, you just put the tape in between the bone of the hip and the lower rib, the midpoint you measure, while that's the waist circumference, while the hip circumference you uh, put the tape at the maximum protrusion of the buttocks and you measure, that's hip circumference. But we'll do this practical during the revision, right? So that you see it live. So I said waist circumference, when it's more than 102 in men is high, when it's more than 88 in women is high. So that's in centimeters. 102 centimeters in men. All these things there in your note. You can refer to your note, but what I'm doing here is more of explanation so that you understand. But they're all in your note. So in men, when it's more than 102 centimeters, in women, when the circumference is more than 88. Abila, no problem. During revision, which will likely be next year, I will come and demonstrate all these things so that you see it, so that it will help you in your practice. Okay, Marcus has problem with his connection. Which line is he using that he has problem with connection? So hope, Kolo, do you understand the explanation on the waist circumference and hip circumference? So waist circumference, the mid, there's a bone on the hip bone here and your lower rib here. So you put the tape in between them, round and measure. That's waist circumference. While the hip circumference, from the maximum protrusion of the buttocks, you put the tape round. That's the hip circumference. Okay. So someone asked, sir, come over. Okay, those who qualified for the surgery are those who have the class 3 obesity, because we discussed the classes yesterday, even we discussed it in the class, right? Those who have class 3 obesity, or those who have class 2 obesity with other complications, such as respiratory problems, type 2 diabetes that is not controlled, hypertension that is not controlled. Those ones qualified for surgery. We have places in Abuja and Lagos that do that type of surgery. Any more questions, or I need 4 proceed so that we'll go to respiratory system. Any more question, or we'll go to respiratory. Okay, so Kolo said proceed. Thank you for that. I need 4 people to write proceed so that we'll go to respiratory system. Okay, so I got my proceed. So another common uh, non-communicable disease is chronic respiratory diseases. If it is acute respiratory diseases like pneumonias, like TB, they are not part of non-communicable disease. So this I'm talking about chronic respiratory disease. So chronic respiratory disease is very common. It could be from dangerous chemicals in the environment or part of occupation, like those who mine, those who break quarries, those who break stones and other things. So this could be their risk. Or those who are exposed to inhalational chemicals like dust, like smoke, like those who smoke cigarette. So these are those people that are risk. So the chronic respiratory diseases are many, but we'll concentrate on the ones that are common. And the common ones are the COPD, chronic obstructive pulmonary disease, COPD, and asthma. Other ones are the interstitial lung disease, sarcoidosis, pneumoconiosis, COVID-19, and other things. But our focus is the common one. So you see why it's important to attend this lecture, so that you will not go and be reading things that are not very necessary. So we know that the respiratory system is very important for the breathing of an individual. And if there's problem with respiratory system, there's risk that that individual may not function properly due to difficulty in breathing, cough, and other things. So it reduces the productivity of a individual, and at the end, the productivity of the whole community. So the chronic respiratory disease affects almost 500 million people and is usually seen more in an affluent society due to industrialization and increase in the rate of smoking. So asthma and COPD actually are the commonest causes of chronic respiratory disease. So we'll start with COPD, chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease, it happens when there is persistent airflow limitation that is progressive and is due to exposure to chemicals or dangerous substances. You know the way the airway is, right? If you take in breath, normally it flows the bronchos to the terminal bronchioles to the lung tissue. But there are situations in which the airway is reduced in size. There's a limitation in the flow of the airway, and that leads to difficulty in breathing, irritation, and cough. So in COPD, there's that limitation, and that limitation is chronic and is progressive. Chronic and progressive. And there are two types of obstructive lung disease. We have the emphysema, you see it in your note, and bronchitis. Let me just type it so that you see it. Enter the chat. Emphysema and then bronchitis. Send. So you will see so I've written it. So the two types of chronic obstructive lung disease, COPD, are emphysema and bronchitis. So normally, the as I explained, we have the bronchos, the bronchioles, and the lungs. So once the flow is limited, or there is the space of the space in the bronchos and the bronchioles is limited, you see that the flow of air to the lungs will have problem. So in chronic bronchitis, the second one, the individual will be coughing, coughing, coughing most part of the year. So the definition, you see the coughing and bringing out sputum for 3 months. And this has happened for at least 2 consecutive years. Let me repeat. In chronic bronchitis, the individual is coughing and the cough is productive of sputum for at least 3 months for 2 consecutive years. That individual is said to have chronic bronchitis. So some people that you have noticed that they are always coughing year in, year out, they should be investigated for chronic obstructive lung disease. While in emphysema is it is a histological diagnosis. You cannot diagnose it clinically until you do take part of the lungs and do histology. There you see that there is permanent dilatation of the bronchioles. So the system of exchange of air in the lungs is affected. Okay, so you will see it in detail in your note. So I don't want you to be confused about that. So you have chronic obstructive disease. Just know that there is emphysema and bronchitis. That's all I want you to know. Don't go deeper, right? Because if you go deeper, you get confused. So chronic obstructive lung disease, there's emphysema and bronchitis. Okay? So what are the risk factors for chronic obstructive lung disease? Cigarette smoking. Anybody in this class that is smoking cigarette, he's putting himself in a lot of risks. Apart from problems with the lungs, people that smoke are at risk of diabetes, they are at risk of hypertension, they are at risk of cancers, especially of the lungs. So there are many risk factors associated with smoking. So if you're smoking, it's advisable that you stop. Okay, so smoking, then exposure to biomass. That's why people in the village also are at risk of chronic obstructive lung disease. Why? If you're cooking with a lot of firewood and you're inhaling the smoke, year in, year out, you will come with lung problems. You will come with COPD. You will come with emphysema or bronchitis because that smoke that you have been inhaling year in, year out will put you at the risk of chronic obstructive lung disease, COPD. That's why we advise women that use a lot of firewood, they should not cook in an enclosed place. It should be in an open space so that air will be taken away most of the smoke. But if it is an enclosed kitchen, most of the smoke they will be inhaling it. And I've seen a lot of women who do not smoke coming to our clinic and our emergency with difficulty in breathing and every feature of COPD because they have been cooking with firewood year in, year out, and is in an enclosed place and it has destroyed their lungs. So, as I said, tobacco smoking. Then we have passive smoker. Let me tell you something. I don't want to affect your friendship with your friends, but if you are a friend of somebody that smokes, you are at risk. Though your risk may not be as his own, but you are at risk. You are at risk of COPD, you are at risk of lung cancer, you are at risk of all the problems that cigarette smoking can cause. So, if you have someone that smokes and you cannot advise him to stop smoking, so I don't know what you do with that friendship because you are at risk of several problems, right? Then I have explained biomass, right? People that cook in an enclosed place with firewood, they have been inhaling the smoke year in, year out. They are also at risk. So, what are the clinical features? So, the clinical features, you will see the slide. Please take note, all of you that are here, the slide on the difference between emphysema and bronchitis is important. Is slide 106. Please take note, all of you. It's very, very important. Slide 106. I'll definitely bring it out in one of your multiple choice questions in your best of five. So the only way you can differentiate the types of um, COPD is some of the clinical features. So if you see that the person is having serious difficulty in breathing, it is likely emphysema. That's one. Because in chronic bronchitis, they have difficulty in breathing, but not as emphysema. Secondly, if you have cough before difficulty in breathing, it's emphysema. But if you have cough after difficulty in breathing, so if somebody is having difficulty in breathing, then coughs is emphysema. Difficulty in breathing, cough is emphysema. But if you have cough before difficulty in breathing, is bronchitis. Let me repeat. This is very important. It's in your slide 106. Please, all of you that are here, take note of it because I'll ask. I'll be guiding you on the ones that I will likely ask because, and also as I said, those who are attend, they will have some bonus mark. Okay, um, so if you have difficulty in breathing, then cough is emphysema. But if you have cough, then difficulty in breathing is bronchitis. Then if the sputum is not much, just small, it's emphysema. But if the sputum is a lot, it's bronchitis, right? Emphysema, they have less infection, chest infection, but bronchitis have more infection. So you go to the slide and read it very well, right? Read it in detail. I'm going to ask, right? But the things that are more practical for you people, very important, is the number one, two, three. The severe dyspnea, which is seen in emphysema, while mild dyspnea, which is seen in bronchitis. The cough after dyspnea, which is seen in emphysema. The cough before dyspnea, which is seen in bronchitis. The scanty sputum, kata, which is seen in emphysema. The plenteous sputum, which is seen in bronchitis. Please take note of that. Okay, so how do they present? They present with difficulty in breathing, cough, and sometimes fever. And sometimes, especially emphysema, you see that they cannot lie down. They will just sit down like this with their hand on their knee and push forward and breathing through their mouth. We call it tripod position. We call it tripod position. Let me write it. They have what it's called tripod position when they come with the difficulty in breathing. Okay, send. So they have what is called tripod position. They stay this way and breathe through their mouth, pause sleep, right? So you can see the tripod position. It's in your slides, you will see it also. So how do you treat them? You treat them by giving drugs that expand the trachea and the bronchioles so the air will go in easily. One of them is salbutamol. All of you know salbutamol, right? Okay. Another one is salmeterol. They all open the airway. Another one is aminophylline. I know most of you have given patients aminophylline. So one of the treatment is aminophylline. You also give them steroids. Steroids reduce the inflammation in the airway, like hydrocortisone, like prednisolone. And sometimes when they present with serious difficulty in breathing, they need oxygen. So you give them oxygen. Sometimes if they have infection, you give them antibiotic. Infection is evidenced by if they have fever and the sputum is much and has changed color, like it's yellowish or greenish. All this indicates infection. So, but as I earlier said, one of the most important steps in the management is that individual must stop smoking. You must, because if the individual is still smoking, no matter what you're doing for that individual, you cannot help that individual. So it is important that that individual stops smoking. Very, very important. Okay. So what is the prevention of COPD? The prevention is to take care of those risk factors, those things that put an individual at risk. So people that smoke, it's important they stop smoking. And that's why the world insisted that the cigarette pack should include the warning sign that those who smoke are at risk of developing lung cancer and other problems, respiratory problems, right? Then another primary prevention is those women that cook with firewood, right? You give the government should give the alternative like gas cookers, but if that's not possible, they should cook in an open space so that most of the smoke will not be inhaled by them, but air will take it away, right? Okay, then but secondary prevention, those that have the symptoms, they should be detected early and treated early to prevent complications. What are the complications of COPD? Respiratory failure. There will be time that they will become oxygen dependent. Without oxygen, they cannot live. If you remove oxygen 1 minute, the whole saturation will go down and they will almost die. So they develop respiratory failure and oxygen dependent. So the aim is to make sure that they do not reach the extent of becoming oxygen dependent. So you treat them early. But if they have become that oxygen dependent, you try and rehabilitate them. If they need a lung transplant, if it's available, fine. If they need ambulatory oxygen, you provide them so that they will not have severe complication. Ambulatory oxygen is the oxygen that is attached. You tie it like a bag while you're walking. Anytime you feel difficulty in breathing, you take in the oxygen. So we don't want it to be at that level. Okay, Nuruddin is asking that the person that smoke and has stopped smoking but is still with his friends that smoke, the person is still at risk. If you are stopping smoking, you must change your friends Because the truth is that if you have smoked in the past, right, and you are already at risk, but the fact that you're supposed to stop smoking, the risks have reduced remarkably, right? But if you're still with the friends that smoke, of course the risk is still there. Okay, so we still have time, but let's ask some question concerning obesity and COPD, chronic obstructive lung disease. If you have question, you ask, or I'm going to ask some questions myself. If you understood, right, understood. If you have question, ask. Obesity and COPD, chronic obstructive lung disease. So that we'll see what we can do again after that. If we can touch something, we do it. We'll try and finish everything before you go on the holiday on 20 something. You people are going on holiday on 20 something, right? Okay, understood, understood, understood. Good. Proceed, sir. All right. Okay. Okay. So let's answer some questions. Um if you're ready, right, ready, so that we can start with some of the questions before we go to the next topic. Okay, so if you're ready to answer some questions, right, ready. All right, so you're ready. So question one. Okay, Abila asks, can we use nebulizer for COPD? Emphysema is the type of COPD. Now you say COPD and emphysema. So yes, you can use nebulizer. Sometimes they will come with what we call acute exacerbation, acute worsening of the symptom. So those ones they need nebulized salbutamol. Those ones you have to use nebulizer to improve, to open up the airway so that the breathing will improve. So you can use it. The treatment is similar to asthma. The problem is that COPD, if sometimes is more progressive than asthma. Asthma, if you treat it, is reversible. So let's answer some questions. A 40-year-old presented to your PHC. A 40-year-old presented to your PHC with type 2 diabetes, hypertension, and respiratory problems. A 40-year-old presented to your PHC with type 2 diabetes, hypertension, and respiratory problems. The weight of His weight was 120 kilograms. His weight was 120 kilograms. His height is 1.7 meters. His height is 1.7 meters. What is the best treatment for him? His weight is 120. The height is 1.7 meters. 120 kilogram, height 1.7 meters. What is the best treatment for him? So A, lifestyle modification. B, lifestyle plus drug. C, lifestyle modification plus surgery. Okay, so as I said, A, lifestyle modification alone. B, lifestyle plus drug treatment. C, lifestyle plus surgery. So you have to calculate the BMI to tell me this answer. Very important you calculate the BMI before you can give me an answer. Give me an answer without calculating BMI. will not be good, will be wrong. So someone is asking, sir, in some cases you can see sputum with blood. So you so can we also relate it to bronchitis? No, sometimes sputum in blood can be from if you have normal catarrh, it's okay. Sometimes when you cough out, you see blood, right? So you have normal catarrh, sometimes you see blood. But if you say it's bronchitis, you must be coughing at least 3 months for at least 2 consecutive years for you to say it's chronic bronchitis. But sometimes even this weather can make you have catarrh, and sometimes you cough, you see blood. It's not a problem. But the issue is if it is at least 3 months with at least 2 consecutive years, right? Okay, so lifestyle plus surgery, very good. Okay, lifestyle plus surgery, very good. What did you get as the BMI? Okay, BMI was 41. That is morbid obesity. So that individual, you as a public health worker, you counsel him on lifestyle and recommend that he should go for bariatric surgery. You should go for surgery. Very good. Very good. I hope everybody got the answer right. You must get the BMI before you get the answer. If you did not calculate the BMI well, you have problem. Good, Salgatu. So you must calculate the BMI to know the answer. Hope everybody understood the answer because in exam everybody will calculate by himself. If you have challenge with the answer right, I'm only giving some seconds because I'm seeing it's only who? Okay, okay, yeah. The answer is C. Bilkis also got it. Please, if you got the answer, write your own BMI. I want everybody to be conversant with the calculation of BMI. So if you got the BMI right, please write it. Write the BMI you got. Don't worry about the one that started to got. Write your own. Everybody write the BMI that you got. So Hassan also wrote her own, but it's still morbid obesity. Okay, just everyone write the one you got. Approximately 42 Sherifat. Okay, well done. Okay, 41.5. Okay. So if you are calculating BMI, calculate it to 1 decimal point, like 40 something point something, not more than one. Hmm? Don't no need to approximate it to a whole number, at least 1 decimal point. Okay. All right. So if you're ready for the next question, right? Ready, ready, let's go. We'll ask. Okay, you can write ready, ready. Let's go to the next question. Okay, very good. So the following, I'm going to ask series of questions so that you just ask them. Okay, let's just go. The following are types of chronic obstructive lung disease, except the following are types of chronic obstructive lung disease, except A. Asthma, B. Bronchitis, C. Emphysema. The following are types of chronic obstructive lung disease or chronic obstructive pulmonary disease, except asthma, bronchitis, emphysema. So what is the answer? If you write the answer, say if you take the option and you just write the answer. You don't need to write C or B, just write the answer. All right, I will go to the next. Okay, very good. Hasana, asthma, right? Very good, very good. Okay, so let's go to the next question. Very good. All right, so the next question is the following are risks of COPD except the following are risk factors for COPD except A. Tobacco smoking. B. Passive tobacco smoking. C. Exposure to biomass from firewood. D. Okay, some people are still writing. Okay. D. Taking of refined sugars. So let me repeat. The following are risk factors for COPD. A, I said tobacco smoking. B, passive tobacco smoking. C, exposure to biomass from firewood. Then D, eating of refined sugars. Okay. Memuna, D is the answer, but write the answer for the benefit of other people. If you write the option, then you write the answer. Taking off refined sugars. Yes, very good. Taking off refined sugars. Yeah, very good. Okay, very good. Taking off refined sugars. So let's go to the last question. Last question. Which of the following type of dash is the following type dash dash is the type of COPD that has more dyspnea. Dash is the type of COPD that has more dyspnea or difficulty in breathing. Shade emphysema from chronic bronchitis. Okay, so which type of COPD has severe dyspnea? As I earlier said one has severe dyspnea, while the other one has mild. One has little sputum, the other one has more sputum, and one has cough before dyspnea, and the other one has dyspnea before cough. So which one has more dyspnea than the other one? Write the answer. Is it emphysema or chronic bronchitis? Very good, Hassana. It's emphysema. Hassana, good. Emphysema. Right. Very good. Very good. Very good, people. Uh, very good. Emphysema. So other two. Very good. All right. So we will continue next week with asthma. We'll discuss asthma. After asthma, then we'll discuss cancers. And cancers will be our last topic. So hopefully we should be able to either finish or nearly finish. We should be able to finish next week by God's grace, if all things be equal. But if we do not finish upper week, you people will still be around. We finish. So the next topic we will discuss is asthma. After asthma, then we'll discuss cancers, and that will be the end. Okay, so any question today? If anybody has any question from our discussion today, please ask any question whatsoever. Uh, Sharifa, right? God bless you. God bless you too. Thank you. So, any question? Does anybody has any question today? Please ask that question. If you have any question, please ask that question. Okay. Thank you, Sharifat. Thank you, Maria Mukhtar. Faiza, here too. Thank you for participating. Abila, thank you for participating. Bilkisu, thank you for participating. who was here also, said said we have answered emphysema says Lois, thank you for participating. Hasana, you were very active, Hasana. Thank you for that. Same as other two Kasim, very active. Thank you. Larava, thank you for coming. Okay, so there is no question. Okay, we are going to see next week. But if there is any space or any period that you're free, please let me know. I'm on leave, so I have all the time to teach you all that you need to do to be good public health workers, to be good preventive healthcare workers, right? So if there's any space that you have, the class rep should tell me on time. Okay? So thank you very much. Have a nice day, all of you. Bye bye.